Thanks so much. I think to steal Tammy's line, you know, I'm really excited and both humbled to be here. But I really want to acknowledge that what I'm presenting on is really not my work. It represents the work of a huge team of staff and clinicians, as well as researchers and our collaborators and partners, many of which are sitting in the room here today. So I sat down and with Kelly discussed, like, what are my kind of content objectives for this talk? And well, as you see, they're not really feasible. So I'm gonna like revisit that and make it an experiential objective that hopefully through this talk, maybe I'll pique some of your interest. You'll hear something about what we do at Casey House or our research activities, and then you'll follow up with me or Caitlin or any of our other partners about what we do. Because I think that's, you know, really what is most important is the collaborations that come out and the work that happens after today, after my 10 minutes. So I will try and give you like a whirlwind overview of Casey House, which opened in 1988. At the time, it was a hospice providing exclusively end-of-life care. So we had 13 hospice beds in this renovated brick house. But as the epidemic and the needs of the community changed, Casey House grew its home care program and community programming. But what we really found was that there was still this huge gap between acute care and then home care, which might be once a week nursing, which might mean your 3 visits from a physio. So we knew this both clinically and from the stories of our clients, but we also explored this and saw this within the research context. So we know that Casey House clients, looking at administrative data and comparing them to the cohort of adults living with HIV in Ontario, that we serve some of the most complex, medically complex. That's because that's what shows up in the admin data, not the psychosocial. We know we also have a very complex client group psychosocially. But so our clients are using 5 to 15 times the intensity of healthcare services than the general HIV positive cohort in Ontario. And so that depends on which services, you know, that's about 5 ER visits on average a year. That's about 28 physician visits a year. And what we see also is that after an admission, and we see this in our admin data and also in our qualitative data, that things don't go so well, right? We did a qualitative study where we followed people over a month through the discharge process and then back, kind of transitioning back into the community, and heard those like heart-wrenching stories of trying to manage with, you know, 5, 6 comorbidities, with their 10 referrals that they're sent back out into the community with their 12 meds. And for many of our clients, that's into unstable housing, food insecurity. And you just see how that can fall apart. And that's what we see also with the admin data, where, you know, when you hear those stories and you understand in that context, it might not surprise you, but probably as a clinician, and I know it shocked a lot of our clinicians, was that it was only about 10% of the people that we could track within the admin data that were picking up their meds within 7 days. So they're sent out with a script. You hope they're going that day or the next, but that's really not what we were seeing. So it took a long time of visioning this and applying and negotiating with the ministry to create this day health program that really was designed to kind of fit in that big gap between acute care and home care. How do we help smooth that transition out of acute care? How do we help prevent some of those ER visits? How do we try and prevent some of those acute admissions? So a lot of people consulted. I'm sure a lot of people in this room were involved in consultations and part of the process in creating and the building of this now 58,000 square foot purpose-built building. And so that added only one subacute care bed, so now we have 14 beds on our 3rd floor, and then most importantly is on the 1st and 2nd floor is dedicated space to our day health program. And with that, we expanded the interdisciplinary team, adding to that a physiotherapist, Caitlin over here, 2 case managers, another massage therapist, so we have 2 full-time massage therapists, and 2 full-time recreation therapists as well. So I was really pleased to have a group of you come to Casey House yesterday and had the really long version of what Casey House Day Health Program is. So I'm not going to give that to you here, but just want to tell you that people can either self-refer or be referred by their clinician, community, organization to Casey House. And then they are assessed to see what's the best fit for them, whether that's an inpatient admission, a respite stay, the day health program, home care, or maybe it's, you know what, Casey House isn't a great fit for you right now, and it might be a referral to another organization in the community. So the day health program is designed, it was negotiated to be a time-limited, goal-centered health service for adults living with HIV who are experiencing or at risk of deteriorating health. So in terms of the goal-centered, it was meant to be very broad in terms of what those goals could be. It could be around pain management or just helping engage people with the health system, people who've had really negative experiences and haven't been engaging in the care that they need. And so kind of building those therapeutic relationships and enabling that connection to happen. And so in terms of the day health program, people are matched when they are assessed at admission to the intensity of service and also the team members that are involved. So there's no minimum amount of contact time. There's no set path at this point in time. It's really dependent on the individual in the moment and can change as they move through the program. So these are just some of the programs that are offered within the day health program setting, and that's the physio space there. As I mentioned, we have 2 full-time massage therapists. We have wellness and activities like a group yoga and stretching and health education programs. So as a researcher, I have now got to my part of this, and I tried to take Claire's lead in trying to integrate the 3 key points that I submitted many months ago into this talk. And so really those key points are kind of a culmination in lots of research work done externally, internally, kind of clinical experience, and also what we hear from our clients. But what I did for the purpose of this talk is kind of artificially to tie it to only one specific research study. So I'm going to talk about a research study and then lead that into my key message and then move on to the next. So the one that I start with is a CIHRR-funded study that is being led by Carol Strake, and it was really to take a participatory approach to the evaluation of the day health program. And so, I think as Richard Harding brought up at the beginning, the importance and the discrepancy between sometimes clients' perspectives and the clinician perspective. So we took a lot of time. We did 7 sessions where we were consulting with clients, and we tried to do this in a way that was kind of building capacity at the same time to be able to have a meaningful conversation about outcomes and measures. And we also did a session with staff and administration. And surprisingly, there wasn't that much discrepancy, I would say, between these stakeholder groups, but really CD4 and viral load was not brought up. And adherence was only kind of acknowledged more on the periphery. But what came out loudest and clearest with the client group specifically was around pain. I would say second was probably mental health, and third was the real desire to find or refine purpose in their lives. Okay, so my key message number 1, which ties to that, is there's an increasing rates of multimorbidity and desire for non-pharmacological strategies for managing pain in people living with HIV. Yet there are significant barriers to accessing rehabilitation still. So my kind of point to ponder around that, or Casey House's point, is, what strategies and evidence-based programs can we integrate right into our day health program to address this? So the second study that I'm going to mention here was a Masters of Physio student project that Kelly and I worked together on, which was really to did interviews with an interdisciplinary group of health professionals who work with people living with HIV, many of which I'm sure are in this room, and focus groups with people living with HIV to really inform the integration of physical therapy within the broader context of healthcare for people living with HIV. And I think, you know, what we heard from this was, what did physio mean to people living with HIV, and what were the perceptions of the healthcare providers? And again, there was a lot of overlap between these two stakeholder groups, but I think that the people living with HIV had a lot more emphasis on the role of physio and physical therapists in their mental health, their independence, their identity, and their social participation. And I think that the healthcare providers did kind of acknowledge it somewhat, but definitely not to the same degree. So my kind of point to ponder here is, in a complex client population, how can physical therapy be delivered safely and effectively in group settings? So sorry, another point that came out of that was the people living with HIV really expressed a desire for both one-on-one and group settings, and really the importance of that social connection within the group settings, but recognizing not everything can be done within that group setting. So how do we operationalize that is the question. So third study, to my third key point, is another Master of Physio student project that Kyle was involved in over there. And this really ties into, and I know Kelly is going to come back to this, is tied to her community-based exercise work. And that, as you've heard about Casey House clients, is probably not going to be a good fit for everyone. So how do we explore readiness and promote increased physical activity within a really complex client group? And I'm going to have to skip over this, but my key message was the complex and episodic nature of HIV and multimorbidity strongly influence people's readiness to exercise. But I think, getting back to the last presentation, what we also heard was really a bit of a missed opportunity. Very few people acknowledged that they'd talk to their healthcare providers about exercise and physical activity, and they had some misconceptions and fears around this. So I think that there is a real opportunity to increase our dialogue about this, about physical activity as well as exercise, and even in our most complex client group. Looking forward, we have lots of great projects on the go, but also looking for other opportunities, including hopefully integrating self-management within a program within Casey House's day health program.